Now. Well, good morning, Donna. It's a pleasure to catch up, and I just wanted to thank you for your time this morning. It's a pleasure to have you here to present to us today. Just for everybody, Donna is the was previously the Barwon Health Wound CNC, and currently Donna is in her own private wound consultancy, but has had an opportunity to evaluate Accel Heal, the 12-day electrical stimulation wound therapy. So yeah, it's with great pleasure we have this chat today, Donna. It's wonderful to see you, and thank you for your time.
Thanks very much, Chris. Likewise, it's my pleasure to share some of my experiences using the Accel Heal device, and the client that we'll be talking about was the first one that I've used it on. So happy to help other people in that aspect as well.
Fantastic. Oh, well, let's kick off with the case study you have for us today.
Great, thanks, Chris. If you could pop the slide to the next one, that would be good.
And I'll just, there we go.
Yeah, fantastic. So the patient history, this lovely gentleman came to me almost 12 months ago. He was referred to my service from the Alfred hyperbaric unit. He's a 76, as you can see there, 76-year-old male, semi-retired farmer. That said, he still quite actively runs a very profitable business from his home. He is in Melbourne, so he's still very much working, and that's still very much his identity. Actually, just pop that back. Let's just flick to the next slide. Thanks, David. So he had immediately, a few years before he came to me, he was on the last of his 3 courses of hyperbaric oxygen therapy. He has essentially maxed out clinically, and I think from a funding standpoint of what he can use in the hyperbaric space. And so they were keen to transfer him to someone else who could oversee his care. Yeah. About 40 years ago, David, he's happy for his name to be shared, and he's given consent as well. So David had a quite significant accident when he was farming as a younger man back in 1977. He had a high femoral amputation of his right leg, significant burns to his body, all over his left leg and further up into his groin area as well. He was in hospital for 6 months, exceptionally unwell. I really think he still has a lot of trauma. He often still, talks about that time in relation to current things he's going through. Before I saw him, he had been just transferred from the hyperbaric unit to district nursing. But as COVID came along, they were keen, for people who could manage their wound more independently to do that, and they assessed him as being in that category. So he was really left to his own devices doing the dressing. He semi-regularly sees his GP when he feels he needs to. They're really good mates. He'll just essentially present there or give him a call whenever he feels he needs to. He has had a history of seeing infectious diseases and dermatology, and there's been no significant recommendation come out of those consults when I unpacked their assessments. He'd also most recently had been to have some vascular scans done, and they were all quite satisfactory, nothing remarkable there. He left with a class 2 garment. which was exceptionally unsuccessful due to a myriad of reasons. I really don't think it was probably the right size or type of garment. And that comes from my lymphedema background as well. I do lymphedema therapy. So he found them really, really difficult to use. He didn't have assistance to get them on. He really, really did need them. He has a lot of fibrosis, as was mentioned earlier. So his whole left leg is one railroad track of scar tissue. So while it doesn't look oedematous, there's little pockets of edema in amongst the scar tissue. And I'm quite sure there's significant venous hypertension and certainly lymphatic compromise. Despite the concern for osteomyelitis, he's had plain X-rays that show there isn't an issue there. However, I'm highly suspect there may be. I haven't been able to get any activity for further investigations happening in that space. Certainly his GP, when David presents to his GP, picks out the bone on one of the wounds, on the one below his knee. So, you know, and looking at what's there, there's a lot of fibrosis in the wounds as well. Biopsies have been unremarkable as far as picking up something in the malignant space. And certainly when you canvass all his past history, and I take a deep dive into clients and their past history when they come by me, as far as dermatology, you know, vascular infectious diseases go, and his GP, they're all really coming to the summation that there is a underlying venous stasis. Yep, so he needs a class 2 compression garment. Hear that a lot. But he just needs really good wound hygiene, wound cleansing. That's been an issue. So David self-cares a lot. His independence is his biggest goal. It's absolutely paramount to him. It's part of his identity, and he needs to be able to manage that wound on his own. And there's been issues because of his very complex pain in getting him to adequately do that. Thanks, David. Thanks, Chris, booking David. So, as I've said, there's lots of scarring and fibrosis, as you'll see from the photos in a minute. Certainly in his history, he had, written down about his sedentary lifestyle, and he does actively wear a lower limb prosthesis, and that's all working really fine. So when it says sedentary, yeah, you would think so from a gentleman like that. However, and he's, you know, in his 70s, semi-retired, sits down a lot for work. However, he is incredibly motivated. It's a wonderful environment to go into his home to do a dressing. He almost has a nice little a dressing room. He has cupboards set out. It's impeccably clean. He's achieved so much in his life without his leg, and he's very keen to tell you how much his leg doesn't hold him back. So although he probably sits, you know, a fair amount, he's also quite active in other aspects. He's also been the carer for his wife in the last few years, who was having some significant cancer treatment, and they're almost he really is her carer. She certainly looks after him quite a bit, but I think more of it is him looking after her, and he's very responsible. So he's quite active. It's really like he just leads a normal life, just doesn't happen to have his right leg and these complex wounds that he's had for 40 years. So he really has been through every dressing you could nearly think of. It was very difficult for me to even suggest a dressing, even though we don't like to be dressing focused, of course, but it was really difficult for me to, you know, call out different names of dressings and unpack that with him without him telling me he'd had that before, he'd tried that before, and this is why it didn't work. But he really settled into using a lot of silver type impregnated foams, sometimes some saw-backed, some surfactant-based and gel-type antimicrobials as well. I initially had popped him into a compression pump just to get some additional lymphatics stimulated. But what he was finding with the significant amount of fluid that was coming out his wound, he didn't like how it pressed on the dressing. He felt the dressings exploded. I don't actually think that happened, but it wasn't the therapy that he really liked. He wasn't keen on getting into a flat knit or a wrap style compression, which I really wanted to pop him into. So that was another reason why we went to the compression pump. So the compression aspect to his care, we weren't able to progress at all. We had just parked that. He knew we were going to get back to it, essentially. So yeah, GP, I've already spoken to that. And look, David's pain, he has exquisite pain. He has a massive history, but it's really hard to unpack with him exactly where he's at. So he'll often deflect comments when you ask him about, what his pain like, even to get, how is your pain today? Well, it's a 15 out of 10, Donna, but he's, sitting there and talking to you. He does self-medicate quite a lot, and it's really difficult to find out how much he does self-medicate, paracetamol predominantly. He has at times with me said, I just need to leave the room right now, when he's been in exceptional amount of pain. So he's very protective in that space too. Thanks. You can pop to the next slide. Thanks, Chris. So here we've got, at the time we started Accel Heal, at the start of October. So we started him off on the proximal wound. You see the photo on the left there, the one just below his knee on the anterior aspect. We've got the electrodes on, and he's got an anterior ankle wound, the distal, what we've called the distal wound there too, which we treated secondarily. So moving right along, the initial 12 days for the proximal wound, you can see there that, particularly in the second photo on the 11th of the 10th, the activity that was happening at the edge of the wound, those granular buds, those granulation buds that were really starting to come through, and a much more robust granulation centrally, really stood out to me. But what was even more of a standout was David's response. After about day 4, 5, Chris and I had a flurry of phone calls about how David's pain had, gone down from this 8 or 9 out of 10 down to about 2 or 3, and it was a perceptible, point in time where his pain became so much improved, and he felt like he needed to tell the world. He couldn't believe he had such an improvement so quickly in the pain. And that wound just, steadily improved. There's lots of little signs. The exudate started decreasing. And within a really short space of time for that wound, we were able to reintroduce a better cleansing protocol. So when I had, gotten David back into surfactant-based cleansers, the debridement, he really needed some more regular debridement. And he can't fund me to go regularly to do that. And he's more than capable of using debridement pads. There was an issue around him reusing debridement pads. So we were able to put a stop to that, and by the end of the first course of the Accel Heal, we had him doing 3 times a week debridement pads properly, and whereas before he would just tickle around the wound to do the debridement, he was able to get really deep into the crevices, get under the edges, and give it a really good clean, and very quickly the amount of exudate had reduced. So it was quite a remarkable start. You can pop on to the next one. Thanks, Chris. So then quite quickly, we were very, very keen to use the second course of Accel Heal for another 12 days on the distal wound on his anterior ankle there. And as you can see, I think it's a much harder beast, this particular wound. I think it has more of a lymphatic compromise, really, really fibrous, very rolled edges, exceptionally fibrotic base, and this wound was the more painful one. So you can see that we've started it on the 13th of October, and very quickly, 7 days later, just some early little signs where I've got some arrows there of more robust granulation cells coming through. So where we had red previously, the quality of the tissue was changing quite quickly. And again, his pain after a couple of days using Accel was remarkably improved. He almost became a different person. Where I'd been managing David for about 6 months, and David knows that it may not be a healable wound. He's really realistic in that way, but he's always held out some hope. But this man's hope, after his pain had gone and he could see some initial changes, he really changed. He just became almost a different person. I've been managing David in a certain way, and I had to change my tact with him quite a lot because of how much he was reinvigorated by the improvement that he was seeing. It almost made him more able to self-care better, and really impacted his independence in that way. His independence being his primary goal that he needs to be able to maintain. So David will call me when he needs me to go, and that it could be twice a week, it could be once a month, when he needs a bit of a top up and someone to reassess what's happening. So then we've got some photos, thanks Chris, that show what's happening within a week or the following month rather. So this is in November, of both the proximal wound and the distal wound. So on the left with the proximal wound there, you can see how much cleaner and how much that wound is starting to contract, and his pain at that stage was remaining down to about a 1 or a 2, and he was starting to get full night's sleep, which is absolutely fantastic. And same for the distal wound. You can see it's a lot drier. So there's, it was really quite edematous. The tissue was edematous before. And particularly what we noticed initially was that central island of epithelial tissue in the middle there of the wound was starting to get drier and grow as well. And particularly the edges, you can see there's almost a bit of a difference there, isn't there, between the 27th, 11th and the 20th of the 12th on the distal wound. The edges are much less rolled and edematous as well. Like the whole wound is changing. At that point in time, because they had improved so much, and we'd had a really good month of more regular and appropriate debridement, I was able to transition David onto some more aggressive dressings that really needed a clean wound base, that he wouldn't have been appropriate to go on to before. And at this point, we're also starting to reduce the dressing frequency. So whereas before it was every 2 to 3 days, we were able to now get him onto every 3 or 4 days, which is a much better outcome as well. And I think we've got another photo, Chris, on the slide following here, that was taken last week. So at the start of March, the proximal wound, it probably even looks better than that photo is representative of. There's a lot of epithelial bridges on the lower half of that wound, and the top half is really epithelialized and really contracting at the edges. It's very minimal exudate coming at that. It's almost revealing more underlying fibrosis as well as it's cleaned up, and I'm able to actually get in there and break that tissue up. And similarly with the distal wound, which he is so happy with, that's the one that really he would like to be much more improved. If one never heals, he really wants that to be the proximal wound. But the distal wound, that central epithelialization island, that's getting larger when we put a tape measure on it. The total surface area of that wound has decreased by about 30%, and that's probably being conservative. And it's just completely coming in. I'm able to get a sharp blade onto that more often as well. And David's able to continue some more appropriate and advanced dressings that he wouldn't have been suitable for before. And the other thing that we've been able to achieve since we had Accel Heal on board, and I believe it's due to his pain reduction and that invigorated hope and his independence, has been the compression. So we've been able to get him into a flat knit wrap and look at other, strategies for reducing his lymphatic load. And that just wasn't possible before in the 6 months that I had been managing him. So look, it's been really fantastic timing for David. I believe that timing and consistency is everything when it comes to wounds. And at other times, perhaps this wouldn't have been appropriate for David, but it really was great timing for him. And it's been a really good learning curve for me to see how it's really enabled him to make really good progress for his wounds. And just the last thing I did want to add, Chris, if I haven't taken up too much time, is David had a third course just before these wounds were taken. They were already moving along okay. He actually went ahead and purchased a third course of electrical stimulation therapy on the Accel Heal. He had about a month and a half earlier to this, so in January, he'd had a freak accident. He was out hanging out washing, and his prosthetic limb failed, meaning he hit the ground like a ton of bricks on the bricks. Yeah, and he spent a couple of nights in hospital. And he just felt as though his pain was going backwards. I don't necessarily think there was anything negative happening with the wounds, but he just felt he almost needed a top up. He felt as though he'd had a setback and needed a top up, and he was more than happy to pay what he needed to get those results. And since we kind of tweaked it, we went back in, had a look at dressings and other things he was doing, and he's kind of off sailing again. So it's been really good. So look, it's even that financial outlay for him. He's a businessman, and that's usually how I interface with David. He loves talking about everything relating to business and finances and how the world works in that way, and he transpires that to how wound works and how systems work in healthcare. And he knows I don't have to work very hard to explain to him the benefit and the cost savings around return on investment and those kind of things, and certainly he sees me a lot less. He hasn't needed me as much, which is a great outcome for him. I still think I'll be involved with him for quite some time, but it's been a really great perfect therapy for David. So thanks, Chris. Is there anything further that I've perhaps missed or you wanted to?
No, look, no, thank you so much for taking the time today, Donna, to share that case study with us. I think it's an opportunity, obviously, for us to share this with your colleagues and other wound specialists about the change Accel Heal was able to make, to this very long-standing wound. Like, and we do also have a wonderful video and an interview with David himself, the client that you just mentioned, on our website. So people can also access that as well, because it really did change his life. And when you think that he's had that accident 40 years ago and has been dealing with these wounds for such a long time, and the therapy has obviously made such a change to his life. And as you mentioned, so interesting how you put it, that he became a different person because suddenly he had quality of life again and could see hope. So so thank you so much for sharing that. I really, really appreciate it. And we'll look forward to working with you and supporting you in the future.
Thanks so much, Chris. It's been lovely.